Okay, I will say just a few words for the introduction of this webinar. It's a great pleasure to introduce this first and opening webinar of the SPR Special Interest Group and Group Processes and Outcomes that I have the privilege to chair. And the six aims are to enhance the quality of group therapy research and to develop new projects and to establish international research networking. We had our first meeting in Krakow at the conference, at the SPR conference, and so it's our first webinar, and we are very excited of that. In the current webinar, two researchers of SPR, well-known researchers, Catherine Eubanks and Giorgio Tasca, will present their work on subject of alliance ruptures and repair, with a focus on the applications in individual and group therapy settings. Specifically, they will focus on the FreeRS, that is a well-known method for measuring and assessment alliance or rupture processes in the session. We know that alliance ruptures were described initially in individual therapy, and usually alliance ruptures are defined as a deterioration in the alliance, which is revealed in the therapy session by a disagreement between the patient and the therapist on the goals, on the emotional bonds. However, the nature of the alliance in group therapy is a challenge, and I think it's a focus of our webinar today, because it's a collaborative relationship with the therapist, but also with the other group members, with the group as a whole, and with all these structural elements simultaneously. So we know that in group therapy, for example, clients consider the relationship they develop with other group members to be as important or beneficial as their relationship with the group leader. And so this interplay between the individual and the group level makes the analysis of the group alliance more complex. And I think it's very important that today we can listen to important presentations on the challenges of measuring and doing research on alliance, rupture, and repair, both in individual and group therapy. So I would like to express my gratitude to Catherine and also Giorgio for their presence. And so I would like to invite them to take the stage and to deliver the presentations. I think that Catherine will start. And so as Marjolaine said, this session is video recorded, and the recording will be available in a week or 10 days in the website of the SPR. Okay, so
Okay, great.
Catherine,
Well,
you can introduce yourself, of
yes.
course.
Thank you so much for this invitation. My name is Catherine Eubanks. I'm currently a professor at Adelphi University. I live in New York City in the United States, and it's just such an honor to be part of this first webinar for this SIG that's looking at such an important area of treatment and research. And as we'll see in the presentations today, George's group has taken a measure from individual therapy and bringing it into the group space. And I think whenever that happens, the findings then come back and help inform and enrich individual therapy too. Like looking at these phenomena in different contexts and from different lenses is such fertile ground for both types of approaches. So I'm really thrilled to be part of this. So let me share my slides here.
Catherine, could you add the spotlight on yourself? I'm not able to do it now, but maybe you do it yourself. 3 dots.
Spotlight this share. I think I just did it.
Okay, perfect.
Okay, so yes, so I'm at Adelphi, where I am part of the Center for Alliance Focused Training, along with my colleague, Chris Moran. And I do want to uh, just briefly note that this work comes out of an alliance focused research program. For many years, we were collecting data at Mount Sinai Beth Israel, a hospital in New York City. We're now primarily located out of Adelphi University. Chris has been the primary investigator on a number of grants funded by the National Institute of Mental Health in the United States. I received royalties from the American Psychological Association. And in this research program, we've had these efforts to define and measure alliance ruptures, to develop and test models of rupture and repair, and to develop training to help therapists with navigating ruptures. And these things all sort of inform each other. So that's the context this is coming out of. So what are alliance ruptures in the context of individual therapy? So building on something Gianluca already mentioned, we often sort of ground ourselves in Borden's conceptualization. It's a very useful way to think about the alliance as the agreement of goals, the assignment of tasks in therapy, and a bond between the patient and therapist. So if that's how we think about the alliance, we can think about ruptures as difficulties with any of those areas, disagreeing on the goals, having difficulty collaborating on the tasks, a strain in the bond. If that's then rupture, then repair could be sort of fixing those things, right? Reaching agreement on the goals, being able to collaborate on the tasks, being able to strengthen the bond. So that can be a useful way to think about what is alliance, rupture, and repair. We can also think about the alliance in terms of all humans having these basic needs for agency and communion. This is something many people have written about. So agency, I have a need to sort of define myself and have a sense of mastery and have a sense of autonomy, and then also a need for communion and a need to connect with others and relate to others. And those needs can be challenging to navigate within myself. And then definitely then when I'm interacting with another person, I have my needs, they have their needs. It's inevitable that they're going to at some point collide, conflict, clash. So in that way, ruptures of some kind are inevitable in human interactions. And that can also include this sort of human tendency to see ourselves as subjects and see others as objects. And it can require effort and work to really appreciate the subjectivity of another person. So that can be these kind of inevitable things that happen in relationships would lead us to expect there will be ruptures in therapy. That's gonna happen. Doesn't mean every single individual rupture is preordained, but the fact that some kind of rupture is gonna happen, we would expect it. And repair could be a process of those two people trying to negotiate with each other and recognize each other, recognize each other's needs, recognize each other as a subject. And that experience of being able to negotiate with another, be seen, and work to see them, and have this moment of mutual recognition could provide a corrective experience. So in that way, rupture repair could not just sort of like fix a conflict, maybe a disagreement we were having in a therapy, but could actually be this very important therapeutic experience. And maybe that's part of why some of the research on ruptures and repairs, some studies actually find that patients who have a rupture that is repaired have, in some cases, better outcomes than patients who reported little to no rupture. There may be something therapeutic about that repair experience. Another way we found it helpful to think about ruptures, and you'll see this a lot as we talk about this measure, the 3RS, is thinking about them in terms of two subtypes. This is coming out of Heather Harper's work and also drawing on some ideas from Horney, we could think of ruptures as moving against the other, where I'm sort of, if I'm moving against you, maybe I'm privileging my agency over our communion. And we think of those are, we call those confrontation ruptures. And we could think of it as moving away. So if I'm moving away from you, maybe I'm trying to prioritize communion, keeping the peace, avoiding conflict over sort of expressing my needs for agency. And then we could think of repair as being able to move toward. I'm not moving against, I'm not moving away, I'm able to move toward. I put an asterisk there because it would need to be like genuinely moving toward. There is kind of a pretending to move toward, which is another form of withdrawal. I'm like, oh, that's a great idea. I agree with you when I don't really agree with you, and I'm just trying to keep the peace. But if I'm genuinely moving toward you, that's part of repair. So these are just different ways of thinking about what alliance ruptures and repairs are. Something I need to say about the word rupture, which is probably not the perfect word, but we've done too much with the word rupture, so we're sticking with the word rupture. But in English, at least, and I'd be curious about, for those of you speaking about ruptures in other languages, if this is true for the word you're using, the word rupture in English sounds like a big clash or breach or tearing apart, breaking apart. And often when people hear that word, they assume we're just talking about big disagreements, things that are very obvious, overt, huge conflicts. Sometimes people will say, well, I don't have ruptures in with my patients. And I imagine they're probably because they're thinking of something really big. But we use this word rupture and apply it more broadly, looking for also what we call rupture markers, these little things that might be pointing to a rupture. They might be very subtle. They might be almost micro ruptures or these little movements that if we don't address them could become something big. So when I'm talking about types of ruptures, I'm not just talking about big moments, but also very small, subtle moments. Okay, so how do we identify ruptures, both as therapists and as researchers? We found it helpful to think about both interpersonal markers, where things that we can observe, and intrapersonal markers. When you're the therapist, you can also pay attention to your own emotional experience. And so the interpersonal markers, these movements against, which we refer to as confrontation ruptures, and these movements away that we refer to as withdrawal ruptures. And the intrapersonal markers can be many possibilities. Each one of us is going to have our own unique reactions to things. It might be you start to realize you feel frustrated, you start to feel anxious, you start to feel bored. I use bored as to prompt me to wonder if a withdrawal is happening, because withdrawals can be boring because people are sort of moving away from emotion and engagement. Maybe you feel distant, maybe, but they're not necessarily negative emotions. There could be something happen. Some people get excited and curious when they're in the middle of a big confrontation. So we're all going to have our own reaction, but something we can pay attention to. Sometimes that's the first, your first clue something may be happening is you may just be first aware of your own emotional reaction to it. So I'm going to illustrate these rupture markers drawing on the 3RS, the Rupture Resolution Rating System. We originally developed this in collaboration with Chris Moran and Jeremy Safran, and we put out a manual. And then, and I know George's group was working with it after we had put out that initial manual. We realized that there were some things about it that it was missing or that we wanted to change, and so then we subsequently revised it in 2022. It's an observer-based coding system, so coders can watch a therapy session and track the occurrence of ruptures and repair processes and how effective the repair is. I have the link there. It's freely available. I'm happy to share it with anybody, and I'm happy for people to adapt it in different contexts. I think that's fantastic. We've been able to demonstrate some predictive validity where finding that like unrepaired ruptures linked to dropout, linked to increases in symptoms, effective rupture repair linked to better treatment retention, better outcomes. So it seems to be doing pretty well, and people have been able to get reliable with it, though it can take some work. It can be challenging. So I'm going to, oh, and just to explain a little bit about the revision, the initial measure focused on patient rupture markers, things patients are doing that make us go, that looks like confrontation, that looks like withdrawal. And then we also looked at how therapists responded to that, therapist repair strategies. And we realized what was missing. Ruptures are dyadic phenomena. Both people are part of, or in the context of individual therapy, both people are part of what's happening. And so what was clearly missing was therapist rupture markers and patient repair strategies. How are therapists contributing to ruptures? How are patients contributing to repair? So that's what we've tried to add in this revised version. And also we've added a working together subscale, which is just trying to help coders not jump too quickly to the rupture markers without just kind of looking generally at the alliance. How well are they collaborating? How's the bond? Some therapist behaviors of accepting and validating and being curious and engaged, and the patient's engagement, so that they're also sort of tracking that. Okay. So I have a few brief examples to illustrate these different types of rupture markers. So you can see the interpersonal markers, and you can also be paying attention to your own intrapersonal reaction. So here's an example of a confrontation marker complaining about or criticizing something about the therapy.
Do I still have to fill out the questionnaire? It takes so much time, and I don't think it's really gonna help.
Okay, so I think it's pretty clear the patient there is not happy with something about the treatment.
Yes.
Another form of confrontation could take is sort of pushing back against the other, defending oneself against the other.
Yeah, everybody does that sometimes. That's normal.
Or trying to control or pressure the other.
Yeah, how does this therapy work? I'm tired of waiting.
And those were some patient examples, but obviously therapists can also engage in confrontation type behaviors. So notice you're going to see and hear the patient talk about her discomfort with the therapist and listen for the therapist's response.
So I wanted to talk to you. Lately, I've been feeling uncomfortable. I just really feel like you're not hearing me.
Feels like that's the same complaint you have about your partner.
Okay. So therapists might have had good intentions around identifying patterns in the therapy and linking it to other relationships, but in the moment for the patient just said that she wasn't feeling heard, and then she wasn't heard. And instead of sort of addressing what might be happening between them, the therapist responded in a way that was sort of blaming the patient, like this is the thing you do out there, and not exploring like maybe what's happening between us and maybe how am I contributing to it. Okay, so those were some examples of confrontation markers. There's also withdrawal, movements away. These can be more subtle and more difficult to recognize. So a few examples of that. Withdrawal could take the form of just sort of shutting down, giving up, going silent, something like this.
It's fine. It's nothing.
Withdrawal could also take the form of, so that was sort of an example of going quiet and giving less. Withdrawal can also take the form of actually saying a lot, but saying a lot that's functions to avoid the work of therapy or to avoid engaging or becoming vulnerable.
Things aren't going so great right now in my marriage. I have this habit with romantic relationships. Once things start going well, I sabotage them. It's like this pattern. Uh, like when I was young, and my feelings of perfectionism and my need to get everything right, and this belief deep down that I don't deserve to be happy. You know, I think it's related to birth order. I was reading some stuff online a couple weeks back, and they said,
okay, so you can see the patient's kind of getting off into like different tangents, kind of intellectualized, like they're talking a lot, but they're really moving away from probably what they need to be working on. So that's another form of withdrawal. Withdrawal can also take this form of sort of masking. I'm not comfortable sharing with you how I really feel, so I'm just trying to kind of smooth it over and keep the peace.
The work was great. You're always so helpful.
Like that. And these examples are a little bit exaggerated to serve as illustrations. This can happen in a very subtle way where you really don't know. You're really not sure. Like, did they find it helpful? Did they not? Something's making me question it, but it's hard to sort of put my finger on. And then, of course, therapists can do this too. So here, patients describing a very difficult abusive relationship with their brother, and listen to how the therapist responds.
So I just feel like every time I get upset, like he gets more upset. And with all the yelling and the, stuff, I really just don't know what to do.
Tell me more about your relationship with your sister.
So therapist just sort of went elsewhere, maybe trying to avoid, maybe they got uncomfortable, maybe we don't know why, but therapists can also sort of withdraw. So to sort of sum up, different forms of confrontation, moving against, different forms of withdrawal, moving away. And obviously in real life, these can be, you can see complicated mixtures where there's sort of moving against and moving away in rapid succession or almost at the same time. Okay, so now let me shift to repair and how do we sort of conceptualize and assess efforts to repair ruptures. And I have a map here of the many roads leading to Rome because we really do think there's lots of options for therapists to use and to sort of tailor to the case at hand. So it's, and then the context of the particular rupture is really important. So it's not like here's the right way to repair, but here's several ways therapists can repair. So we've conceptualized this in terms of 3 pathways, all moving from some acknowledgement of the rupture, which could be explicit, or it could, sometimes therapists don't say it out loud. They just recognize it and think about it, and patients also, I should say. And what we're hoping to get to is that new relational experience, that of mutual recognition, of really being seen and respected and understood and appreciated. So we can get there through several different pathways. I'm going to focus on these first 2 first. Chris and I refer to these as immediate because they're usually sort of happen right away and they're sort of quicker moves. The first pathway, clarifying understanding or validating feelings, can be very much things therapists are doing all the time anyway, and sort of part of building and maintaining a good alliance. If something's unclear, just clarifying it. If you pick up on some negative feelings, validating those. Then The next path, renegotiating tasks or goals. So particularly if there's a rupture related to some sort of disagreement or issue with a therapy task or with what we're working toward, several different ways therapists could try to repair that by focusing on that. They could discuss changing it. They could change it. Sometimes just discussing changing it is sufficient for the dyad to sort of get on the same page. So they could be, because it communicates like an openness to hearing the other person out. So discussing changing it. Sometimes the task needs to be better explained. Sometimes the confusion or disagreement is around not really understanding the task or not understanding why the therapist is recommending it. So explaining the rationale can be helpful. And then this last one, redirecting back to the task. With that, we're trying to capture, sometimes the dyad kind of wanders away from something and maybe through withdrawal, and then the therapist or the patient may realize, oh, let's get back to this thing. And so that's like sort of redirecting back to the task following a withdrawal. And then there's, so that's sort of the immediate pathways. And then there's this more exploratory pathway where the rupture becomes the focus and we really dig into exploring the rupture itself. Exploring those negative feelings in depth. There may be efforts to avoid that. Like as we try to explore, it's hard to talk about this difficult thing happening between us. One or both people may be tempted to try to avoid it. If you can catch that avoidance and then explore that, like what's hard about talking about this right now, and hoping to get to recognizing the need underlying it, like those needs for agency and communion, for example. So, for example, with withdrawal, trying to support moving towards helping the person more directly assert what they need. And then with confrontation, trying to help the person kind of access the vulnerability that we presume is underlying that, the need for communion that may be underneath the more overt expression of agency. In the 3RS, we can sort of categorize these forms of exploring the rupture in terms of validating the other's experience of the rupture. It makes sense that you're frustrated right now, for example. Inviting or starting to engage in an exploration of the rupture. Can we talk about this? Exploring avoidance of the rupture, if that happens, and or redirecting back to the rupture if we start to talk about it and then sort of move away from it. And then also disclosing one's internal experience of the rupture. Drawing on, my experience, I feel like I'm walking on eggshells. I feel like we're dancing around something. I feel like we're in a power struggle right now. These can be useful tools for inviting both people to collaborate on an exploration of the rupture. Yeah, I think I already said that. Okay. A few more strategies that could be part of either sort of an immediate focusing on the task or a more in-depth exploration of the rupture. Acknowledging your contribution. So being open to, I'm somehow part of this, whatever this is. Maybe I wasn't clear. Maybe I was rushing you. Maybe I'm pressuring you. Maybe I'm missing something. Acknowledging our part. Linking the rupture to larger patterns. This could be linking this thing now. Oh, we're doing that thing again. That's a pattern. We've done this before. We've been here before. And sort of drawing attention to how this is part of a larger pattern between us, or how this is part of a larger pattern for the patient in their life. What's important with these links, they can be very useful. They can help the patient with generalizing what they're learning from this rupture to other things. They also help address the question of like, I didn't come to therapy to talk about my relationship with you, therapist. And this sort of helps underscore why this might be helpful to talk about our relationship. This may be part of a larger pattern. But therapists need to also be mindful of not using this as a way to avoid. So if talking about us is getting challenging for the therapist, it may be tempting to shift to, oh, this is just like that thing with your partner or your parents or something, as a way to avoid talking about us. So you don't want to do it in an avoidant way, but really explore what's happening between us and really dig into that. And then once you feel like you really have worked on that, then it might be helpful to link it to other relationships. So, and what I'm saying there is that like the same move can contain elements of both rupture and repair. We can be trying to repair and inadvertently rupturing at the same time. And by the same token, there can be a move that we're first struck by the rupture in it, but it may contain the seeds of repair. The patient moving against and complaining about something could also contain in it the seeds of, they want to talk about what we're doing. They want to work towards some kind of collaborative agreement. And maybe their first effort came out a little too hostile, a little too strong, but there is a desire there to connect. So I wanted to show one brief clip of a little bit of rupture and repair. This is me with an actor playing a patient who's come in with, he's frustrated, he's having trouble in his relationship with his wife. He's talked some about his frustration with his wife, but he's also kind of mentioned some dissatisfaction with the therapy. And so I want to invite him to talk more about our rupture.
I'm wondering how you're feeling about how we're working together about this. I mean, I understand you're trying a lot of things with your wife, it's not working. You also expressed some frustration with our work. Could we talk about that for a second?
Yeah, I just feel like we're not really getting anywhere. Like, you know, I expected a couple sessions and I'd be like set, you know, and it's not that way apparently. And it's just, you know, I mean.
Can you say a little more about what you were hoping for?
I was hoping that you, especially as a woman, would be able to tell me kind of like how to like work with another woman, you know what I mean? It's like, I don't know, like I've never been great at relationships in my life, but I'm pretty good with guys because we, you know, we golf together, we talk about stuff, you know, sports, whatever, but women, I mean, it's just a foreign thing to me. I don't get it. It's like, I can never please her, I can never make her happy, she's always mad or upset, we're not talking to each other. Can you give me some information on how to make that better?
So what I'm wrestling with right now is while we can keep talking about things that I think could be helpful, but at the same time, if you're hoping that I kind of have access to the secret key to working things out with your wife, I'm not gonna have that. You know?
Well, that upsets me because, you know, pay good money coming in here, and it's like, you know, you want to get answers. I go to the store, I want to buy something, I get it, I bring it home, it works. You know, I come here, I pay money, things aren't working. It's not getting any better. Like, I'm trying to be better at home, but I'm not really getting the concrete, you know, guidance that I thought I would get here. And it's it's upsetting because, you know, I'm upset there. I came here for like relief, and I'm not really getting it. You know what I'm saying? So. Why is that? Why can't it be, you know, an easier thing to tackle? But I don't want you to feel like, you know, like I'm not.
What just happened? There was a shift.
Like, I'm not trying to like get you upset, okay, or for us to have like some kind of, you know, altercation here about this. I mean, that's not helping anything. But you know, I just feel like. You know, there's nobody else I can talk to, and when I come here, I try to open myself up a little bit.
Yeah.
And it's really hard for me to do that. And I'm not. For what reason am I doing it if I'm not getting answers?
You're laying it all out there.
And I don't want to like, you know. I understand you're very well trained, you're a professional, all that stuff, but you know, last thing I want to do is alienate you.
Did it feel like that's what was happening?
Yeah, I feel like, you know, driving over here, I was pissed.
Yeah.
I'm like, here I go again to see Catherine, and like, what's going to happen? I'm going to drop another $100 or whatever, and I'm going to come out feeling the same crappy way I feel going in. Why is that? You know, if I go see a doctor and I got a busted leg, he sets it, puts it in a cast, and off I go. He fixes it. You know, I guess I need to be fixed, or something needs to be fixed.
and I feel I'm kind of torn because I feel the desire to fix things, and I do feel a pull to give you a whole bunch of suggestions. But I also think there's something important happening right now, maybe for us to look at.
Okay, so I hope I picked this clip because it had several things in it. There was efforts to explore the rupture. I was disclosing some of my experience of what was happening. There was also, in the context of it, he's sort of wanting something, and I push back against him a little bit. So there's some therapist confrontation as part of this, negotiation process back and forth. I'm also trying to validate his disappointment and get him to let's kind of dig into the details of what he's finding disappointing and frustrating. And then tracking as things change, right? So the rupture can shift and we've got to move with it. So initially he was showing more confrontation markers, but then he withdrew. He had that moment where he kind of went silent and pulled back. And so, well, what's that? What's happening there? What's happening now? And also, as you can see, that it's not like rupture, repair, it's done. There's going to be back and forth, tacking back and forth, both people continuing to be part of the rupture and repair effort in various ways. So I hope that gives you a little picture of how complex these processes can be to navigate as a therapist, how complex they can be to try to track as a researcher. And then George is going to up the complexity many-fold by bringing more people into the mix. So thank you for this opportunity, and there's my contact information, and I will stop sharing.
That's great. Thank you. Thank you, Catherine.
Giorgio, I think that we can have a discussion at the end of your presentation, and so.
Okay, for both.
Yeah, for both presentation.
Yeah, that sounds
so
fine.
You can go now. Okay.
I'll share my screen then. All right. Is that good for everyone? Yeah. So as Catherine was saying, our plan and our goal was to take the 3RS and use it in a group therapy context for some clinically and also for some research purposes. And so at the beginning of that process, we basically took the 3RS and we looked at videos of groups and realized, well, this isn't quite going to work in the way that we'd like it to, because there were too many things happening that were difficult to understand and to conceptualize. So we took a step back during that process and decided to look at a different way of using the 3RS within groups. And in order to do that, we had to not really adapt the 3RS, but add something to it in order to use it for the more complex sets of interactions that occur in group therapy. And so I subtitle, or the title of this is a group rupture and repair system, rating system, the G3RS, but the subtitle is extending rupture and repair theory to groups because of the additions that we had to make. I guess I should introduce myself. I'm Giorgio Tasca. I'm a professor at the School of Psychology at the University of Ottawa. And I've been here for almost 9 years now. But prior to that, I had a long career in the hospital system, mainly doing group therapy. I continue to do groups now, but I had a long clinical career prior to what's become mostly a research and academic career. I'm also the director of the Psychotherapy Practice Research Network, which is a collaboration among a number of practitioners and academics to do practice-based research. Before I get started, just some acknowledgements. The research that I'm showing you that I'll present today a little later on, and some of the clinical applications come from the dissertation by Danielle Baldwin, who's a doctoral student of mine at the University of Ottawa. And we had a couple of very dedicated coders, Camille Garceau and Justine Braham. And of course, Catherine was instrumental, particularly early on, and continues to be, with training us on using the 3RS. Well, I'll talk about that a little later. So, as Catherine was saying, individual therapy really is a dyadic process, and the rupture repair process in individual therapy includes, the therapist and the patient both potentially engaging in ruptures and repairs. The rupture target, if you like, who the rupture is aimed at, is typically in individual therapy is the therapist. And that's sort of, especially from the perspective of the first iteration of the 3RS, the therapist or the therapeutic relationship. And so as Catherine defined earlier, there are withdrawal ruptures and markers of withdrawal ruptures and confrontation ruptures. As I said, the target often is more often is the therapist, and that means that the initiator, if you like, of the rupture is the client. And we introduced the language of target, initiator, and target because it became important in the context of group therapy, and I'll describe what I mean by that shortly. In terms of repairs, typically it's been conceptualized in terms of, although that has changed somewhat in the new version of the 3RS, but typically it's been conceptualized as the client or the relationship as the target of the repair behavior, often initiated by the therapist. What happens in groups, if you add more people together, things happen, as those of you who do group therapy will recognize. There are multiple and simultaneous alliances that occur in groups. There are individual members who might have an alliance with other group members. A particular member might have a particular type of alliance with or quality of alliance with the therapist. And then there's the group as a whole, which we treat as a entity in and of itself. And so there are multiple potential initiators and targets of ruptures and repairs related to members, therapists, multiple members, therapists, and the group. The other thing that has become obvious over time, which we have not coded for or done research on, is that there are multiple bystanders of these processes. There are, unlike individual therapy where it's just two people, there's a rupture and those two people experience the rupture. In groups, there might be a rupture between a member and a therapist, but you've got other group members who are experiencing this as well, even though they're not directly involved. And so and the same with repairs. A repair process between two people in a group might affect a third person in a group. I had an experience not too long ago with a patient graduating from a therapy group that I was doing. She was graduating, she had done well and was ready to leave. And she started the group several years ago, extremely quiet and almost fearful, and evolved over time as an emotional leader in the group. She was a valued and important member of the therapy group. And so as she was leaving in our final sessions, I asked her what changed, like what happened, like how, partly because I was curious and partly because I wanted the other group members to hear and experience that. And she said to me, she recounted to me something that happened a couple of years ago, halfway through her therapy, in which I apologized to a patient. I apologized, and I said I regretted something that I had said, and that was tremendously important to her. She wasn't involved in it; it was a different patient, but she observed this, and given her history, especially with men in authority positions of authority that had taken advantage of her, this was an extraordinary experience for her and had a tremendous impact on her outcome. Again, she wasn't directly involved; she was just an observer. So that's one area that remains, I think, remains to be researched and properly understood in group therapy. Another one is the co-therapy context, where there might be difficulties or issues of rupture between co-therapists, particularly I would say particularly in situations where the therapists don't know each other well or have different approaches to the group, or where there's a hierarchical imbalance, where there's a trainer and a trainee context. Oftentimes, my experience, at least as the trainer, is that sometimes a trainee becomes very silent or very quiet in the group, which is unusual for them, because they don't want to step on my toes, basically, as their supervisor and trainer. So there's a lot of complexity introduced by the multiple individuals in a group context and the group itself. So we, as I was describing earlier, in our initial attempts to use the 3RS in groups, it was very useful and helpful, but then we ran into sort of limits of the 3RS. And in order to deal with those limits, we decided to not only code ruptures and repairs the way the 3RS does, but also to indicate who is an initiator and who or what is the target of the rupture or repair. So is the initiator the therapist, a member, or the group, or of the rupture, and is the target the therapist, member, or group? And the same for repairs. And in that way, although we were working with the first version of the 3RS, we began to move towards the second version of the 3RS, because now we have members and therapists who are potentially rated as initiators of ruptures and repairs. We didn't do that on purpose, but it ended up working that way. In order to help us with that, not only are we coding initiators and targets of ruptures and repairs, but we're also looking at concurrently the structural or relational level of the group in which the interaction is occurring. So is it again, borrowing here from Gary Burlingame and Bernard Strauss's work in the Handbook of Psychotherapy and Behavior Change, is the interaction occurring member to therapist, member to member, and member to group. And in our coding system, the first letter, M, in member to therapist is the initiator, and the second letter is the target. So member to therapist would be the member initiating a rupture, and the therapist being the target. Member to member, the member is the initiator, another member is the target, and so on. After sort of working with in this process and coding a lot of videos, we developed and put together the group rupture repair rating system. Following Catherine's lead, we put it on ResearchGate and make it publicly available so that anybody could take it and use it and modify it and do whatever they would like to do with it, primarily to advance research in this area. as I said, the G3RS builds directly from the 3RS framework. It essentially borrows it almost entirely, coding withdrawal and confrontation ruptures and repairs. We explicitly code the group structural or relational level by identifying who initiates and who is the target of the rupture or repair, member, therapist, or group. And, with I think the exception of the issues around bystander ruptures and or experiences of ruptures and the co-therapist, because we didn't have examples of that, except for those situations, I think it does a reasonable job of identifying ruptures and repairs in a group therapy context. Here we go. The other thing that became apparent to us in working in groups is that we, especially with regard to looking at the target of a rupture or repair, is that we couldn't really rely on who the person was talking to in order to identify the target, right? It wasn't that clear always. So, for example, it happened rather frequently that a therapist in a repair process would be talking to the group, but it's a repair about another member. And so that level of inference became a little bit tricky, although I think it's doable. So unlike the 3RS where it's clear who they're talking to, it's not so clear in groups because of the multiple people and interactions that are occurring. So that's another level of complexity. In terms of ruptures, in our research anyway, we identified, we don't have therapist ruptures here. Again, we were working with the original version of the 3RS. So our ruptures were member to therapist, member to member, member to group, the group as a whole. And another particular thing in groups is that we also identified ruptures that were group initiated, so group to member or group to therapist. I don't have videos the way that Catherine had, but I've got some examples written in text so that we can look at these different examples. A member to therapist rupture, very similar to what you see in individual therapy. It's a rupture related to possibly to the progress or goals or tasks of therapy or the relational bond, or the parameters of the therapy. So in this example, this member is in a group that's part of a study, a randomized controlled trial, and so the video and transcript come from that context. And the group member says to the therapist, but I had another mixed feeling because there's also an ulterior motive to this group therapy, because you guys, the therapists, are making a study. So I'm here helping you, but you're supposed to be helping me. And then they laugh. So this is a confrontation rupture, complaining about some parameter of the study treatment, and it's a member to therapist confrontation rupture. As I said earlier, a peculiar or particular issue in group therapy is that the ruptures might occur also between members. So this might be one member discussing their relationship with another member, or discussing some tension, or there being some tension or something issue in their interaction between two members. You could consider this in some ways a kind of transference reaction, maybe, or some reaction of a member to another member's attempted intervention. So in this example, the one member says to another member, well, half the world feels the same way you do. Right? So a member-to-member confrontation rupture, criticizing, basically. And a second member, the member who was the target of this, replied, yeah, maybe. So here, a member-to-member withdrawal rupture shutting down, essentially, in response to the confrontation, the previous confrontation. And then, a second thing that's particular to groups is ruptures related to the group. Again, in this context, as many group therapists know, the group itself has its own characteristics, climate, or aspects that one has to take into account. And so the group itself can be an initiator or a target of a rupture. In this example, Ray says, I really want everyone, referring to the group, I really want everyone to start crying and screaming. We're all too polite and too reserved, and we don't have much time to the group. This is a member to group confrontation rupture. We can also see member to group ruptures that are related to the member's sense of belonging to the group, or that might affect their need to belong to the group. Their belonging might be threatened in some way. In this case, Nico says about herself, she says, I'm feeling selfish because I feel that I'm not really worth it. Right now at this point, I'm taking too much time from you guys, speaking to the group. There's a brief pause. And then she says, Jane, and to another group member, how did things go with your sister? We coded this as a member to group withdrawal because she was switching topic in the group context. Ruptures can also have the group as initiating them, right? And for our purposes, in terms of our research, and again, this is sort of up for grabs, but we had to make a decision about how to do this. We decided that if half or more of the group members were colluding on a rupture, then it was a group-initiated rupture, essentially. And a lot of this depends on nonverbals, because so you have to see this happening in order to code them. So in this case, Lise says, but I think for the three of us, referring to other group members, we have doubts about this therapy, right? And the other group members are nodding in agreement with her. This is a group to therapist confrontation rupture. In a second example, Sue says, so I do sort of judge myself a lot for that. And so being validated by the group, that really helps. And there's a 15-second pause where the group doesn't respond to her. And we coded that as a group to member withdrawal. She had made a bid for support or response, and the group didn't respond. The same principle applies to coding repairs in groups as well. And so in this way, we coded therapist to member and repairs, which are, again, similar to what you might see in individual therapy. But there are therapist to group repairs as well. That should be T to G. Member to therapist repairs, member to member repairs, and then group to member and group to therapist repairs. So there are multiple types of repairs or structural levels at which repairs might occur. The other thing that, as I sort of alluded to earlier or mentioned earlier, is that in terms of repairs, the recipient of the repair may not match who the target of the repair, of the rupture, right? So, or of the repair. And so therapists might address the group to repair a rupture occurring with a member. In this example, the therapist says, I'm going to interrupt you, Pauline. because I wonder if maybe we're getting a bit off track. I'm curious about what the group thinks about what you're saying. Would it be okay if I check in with them? That's a therapist to member repair, changing task. Pauline says, okay. And then the therapist says, does anyone in the group have any thoughts about what Pauline is saying? The comment's directed to the group, but the repair is with Pauline. We coded that as a therapist to member repair, inviting thoughts and feelings from the group. So I'm not going to give all of the examples because it gets there are a bit too many of them, but I'm going to stick to the ones that are particular to group therapy, member to member repair examples. The therapist says to Amir, Amir, I notice you've been quiet this session. I want to check in with you. It's a therapist to member repair. Amir responds, so I'm just listening. Member to therapist withdrawal, minimal response. Misha, another group member, to Amir says, you've got a lot going on right now. That's a member to member repair. And Amir, again, withdraws by just saying, yeah. Member to member withdrawal. And Sam, a third group member, says, I'm just concerned that you're going to kind of take yourself out of the group because of what was said. I know it was hurtful, but in that way, you won't be able to use the group to help you. And I know you're going through a difficult time, and I'm concerned that you're kind of missing out on what we can help you with. And that's another member to member repair attempt. As I said earlier, groups can also, you can conceptualize at least groups initiating repairs if at least half of the members are collaborating in the repair attempt. In this example, Melissa says to the therapist, we don't mean to gang up on you. This is a member to therapist repair. It could also be a group to therapist repair, depending on the nonverbals from the other group members. Yvette agrees with Melissa, and Melissa apologetically says to the therapist, I think some of us are just frustrated, and several members nod. And that's both a member to therapist repair and also a group to therapist repair, because a number of the individuals are agreeing with Melissa. And the therapist to the group says, I understand, maybe we can explore that frustration a bit. And that's a therapist to group repair, inviting the group's thoughts and feelings. So we developed the G3RS as a companion to the 3RS, primarily to see if we can make use of the complex interactions in groups and also to code some of these interactions. It's not perfect, but I think it's a good first step in the sort of development of and conceptualization of ruptures and repairs in groups. We've conducted a few different studies using the G3RS, and they're kind of in various stages of development of completion. Some of them have been submitted for publication. Some of them are in a revise and resubmit process. So you'll hopefully see those published in the next months. The studies involved a video recording from 3 previous clinical trials of group therapy. So we had video recordings of these groups. There were 160 patients with binge eating disorder in these groups. There were 21 groups and 15 group therapists. The treatment was group psychodynamic interpersonal psychotherapy for binge eating disorder. We had 3 coders who were trained with the 3RS and with the G3RS, and we coded transcribed videos from 62 sessions of the 21 therapy groups, an early session, a middle, and a late session. That should be 63, but one of the sessions was not the video quality wasn't good enough to code. The patients also completed an outcome measure, the IIP, pre and post treatment. And just some preliminary findings, just to sort of illustrate how we think this supports the notion that the different structural levels of group interactions need to be taken into account when considering, when coding for ruptures and repairs. Most of the ruptures were withdrawal type, about 80%, 81% of them. So, 63% of the ruptures were initiated by members with the therapist as a target. So member to therapist, more than half, but more than a quarter of the ruptures were initiated by members related to other members. So a quarter of all ruptures were specific in that sense, member to member, and another 11% were involved the group in some way, as a initiator or as a recipient of a rupture. In terms of repairs, about 70%, 69% were initiated by therapists, and almost most of those, 90% of those, were therapist to member, to an individual member. But 31% of all the repairs were initiated by members. So members actually participated in repair processes in the group, and the majority of those were member to member, one member to another. There were very few total repairs initiated by the group. Whereas we had about 11% of ruptures involving the group, very few of the repairs initiated by groups. We had decent inter-rater reliability. I think at the point where we struggled with inter-rater reliability had to do with the group-initiated rupture and repairs. That's partly a statistical issue because the low frequency of these events meant that the statistic resulted in a lower ICC, interclass correlation coefficient. We found some evidence that higher frequency of member to therapist and member to group ruptures early in therapy were related to poorer outcomes. It set the group on a trajectory of poor outcomes, basically, when it was particularly member to therapist and member to group. And we found a complex finding where a higher frequency of therapist repairs was associated with poorer outcomes. That's probably because they were connected to ruptures, but therapist repairs were associated with poorer outcomes only when member repairs were low, which is a complex finding, which we think has to do with when members are less involved in the repair process. I would say that the group engagement in general would be poorer and therapist-centric, and that I think made a difference in terms of outcomes. In closing, I think some places where we can go with this in future is a very interesting phenomenon of bystander ruptures and the effects of repairs on bystanders, and particularly in the context of unrepaired ruptures and the impact on other group members, but also the effects of repairs on a group member who's not involved in the repair. And the co-therapist ruptures and repairs, I think, might be another particularly interesting area of research to go in terms of understanding these phenomena. And in terms of using the G3RS, I think it could be helpful in helping us to more precisely identify ruptures and repairs, like where they happen in the group, and particularly in identifying complex communication patterns in groups that we know occur but are hard to quantify. And you have questions, for example, like, do certain types of ruptures, member to therapist or member to member, result in worse outcomes relative to other types of ruptures? I think it might also lead to more nuanced understanding of repair mechanisms in groups, how they function, with regard to particularly who initiates them or what the impact of indirect repairs are. And another question that came from a case study that we did a few years ago: should the repair level match the level at which the rupture occurred? So if a rupture was member to member, should the repair really be member to member as well? And I think it might also be useful in training therapists to understand the interpersonal processes and the various levels of interpersonal interactions in groups, and to intervene more precisely depending on the level of interaction, member to member, member to therapist, and member to group. And that's my contact information. Thank you for being here, and thank you for listening to me.
Thank you, both.
So I don't see Gianluca on my screen. Oh, there you are. How do you want to proceed at this point?
I think that's we can see if there are questions or comments. We listened to very, very, very interesting presentations, both from a research but also a clinical perspective. So I think that's a great job. And so I'm curious to see what people think about these concepts. I don't know if someone would like to start with sharing impressions or comments.
I can.
Okay, go.
I'm Ina Hogeband from Holland, and I work a lot with groups, and I work with psychodrama, so with role play. And that's how I'm wondering, like, how can we measure rupture and repair when doing role play, when creating situations, not between members, but between the head person that is in the play and the antagonists.
That's interesting. I've not done much of that kind of work. I mean, there are two levels happening here, right? There's the play level, what's happening in the context of the roles, and then there's the role players, who I assume are patients, and their relationship to the therapist. So you might, for example, see, in that context, you might see resistance or confrontation with related to the role that they're being asked to play. So the therapist, the relationship of therapist to participant with regard to the task that they're given. So that, I think that's one level that could be looked at, but I think there's a second level that you alluded to, which is what happens in the role play, and again, it depends on what the goals are of the therapy. But if the content of the role play itself is important for the therapy, then you might want to consider coding that as well. Some of that might be determined by your instructions, right, of the role play, but yeah, I think there are two levels at which you have to code rupture and repair in that context. I don't know, Catherine, if you have any.
I was thinking the same thing. There's the rupture around the psychodrama task, like I don't want to do that, or whatever, yeah. And then there's what's happening in the exercise itself. Yeah, I agree.
Well, I'm also thinking, like, we create ruptures. Doing the psychodrama, we create the ruptures. and we try to create the repairs, not particularly by the therapist, but by the co-players or the group members. So I don't think there's an answer, but I'm thinking about how to use that in psychodrama. I think it's interesting.
If you're creating sort of rupture and repair scenarios in interpersonal context, for example, then I mean, it's interesting because then the 3RS or the G3RS in that context is almost an outcome measure of whether or not they successfully were able to engage in the task and you know, to repair, to have the rupture and to repair it.
Yeah, which is nice because psychodrama is so difficult to research.
Yeah.
Thank you.
Yeah.
Yeah, you know, I think that there is very little research on psychodrama groups, so it would be very important to adapt the 3RS for groups to the psychodrama settings, because, as you said, there are a lot of differences between the psychodrama groups and verbal groups. So
yeah,
it could be useful to adapt the 3RS to specific group settings.
Yeah, yeah. In a sense, the client's willingness to go along with the psychodrama task is an aspect of the therapeutic alliance, right? Are they in agreement with the task itself? And so that's I think that'd be interesting to code. There's a question in the chat about how do you deal with member-to-therapist ruptures that a client expresses over an email but downplays when the therapist brings it up in the session. That's always fun. I would say that the rupture happens in the session with the group and the therapist. I mean, yes, it's happening in the email as well, but you know, as with many things in group therapy, I often encourage, if a client says something outside of the context of the group, I often encourage them to come back to the group and talk about it in the session. So I think downplaying it is a withdrawal rupture, and it needs to be treated that way. I imagine that does that happen in individual therapy as well? I guess it does.
Oh yeah, totally. Yeah. And I think, yeah, it's one of those moments where it's important to stay with the rupture that's happening right now. So the email might have been, I hate everything, very confrontation tone, but in the session, maybe it's withdrawal. And so that needs to be explored. What's happening right now?
I also have a question for both of you regarding the moderating role of patient diagnosis, because I think that characteristics of patients, and especially characteristics of psychopathology, can have an impact on the patterns of rupture and repairs. So, for example, Giorgio, I think that if you lead a group with patients with borderline personality disorders, the level of conflict and the level of confrontation can be very high, and so it can be challenging. And the same in the individual therapy. I think that the patterns of rupture and repairs can be very different with patients with personality disorders or patients with anxiety disorders, for example. And I don't know if there is any evidence on the impact of patients' diagnosis on these patterns of.
Yeah, that would be very interesting. Maybe Catherine knows more about this. I can tell you the binge eating disorder patients, we've done research with them on using the circumplex model, like the IIP, and most of their problems are in the sort of the lower quadrant, so submissive, friendly submissive, and so a little bit hostile submissive. So that's where primarily the problems are. So the fact that the 81% of the ruptures were withdrawal ruptures is not, so in that context, is not surprising. But we didn't have a comparison group to look at. Catherine, you probably have more to say about.
Yeah, I mean, this is still a relatively small body of research, so time will tell. But so far, the findings are kind of what you would expect, like diagnoses where you would expect more confrontations will have more confrontations than diagnoses where you would expect more withdrawal. One thing, and this is a speculation of mine based on very little evidence, so to take this with a very big grain of salt. But we've seen, like one of our first studies with the 3RS, we had a sample of anxious, depressed people with cluster C personality disorders. So lots of withdrawal was what we found. That made sense. In that sample, what predicted dropout was confrontation. And then in a collaboration with Tali Boritz with a small sample of patients with borderline personality disorder, lots of confrontation, they actually found more connection between withdrawal and poor outcome. And so I was curious about, is there something about ruptures that are maybe less common or more easily overlooked, or the therapist isn't as used to handling them, or something? Like, what's kind of tougher for you as a therapist, withdrawal or confrontation, might depend on what's the norm with that population or something. I don't know. I'm speculating, but I think there's a lot of interesting questions here that we can hopefully answer as we do more research on it.
Can I say something?
Yes, of course.
Thank you for two very interesting presentations. I just wanted to thank you, but I don't have maybe so many intelligent questions, but I'm wonder about what's the difference between this and the group questionnaire, which is going to be presented at the next SPR by Gary and Bernard. I wonder because you have, if I understand you correctly, Giorgio, you have one outcome measure, namely IIP 32. So how are you connecting these ruptures and repairs to outcome? I don't know if that's
Yeah. Well, what we did in the study in particular was we basically looked at the frequency of ruptures and repairs at different times, early, middle, and late, and then correlated them with a pre to post residual change in interpersonal problems measured by the IAP. So it's a very, in some ways, a very typical process outcome research study. The difference with the group questionnaire is a self-report measure of of group processes, and which is useful and certainly convenient. I would say that for some group processes, it's more, I think, more helpful to it's difficult to capture some group processes by self-report, largely because of self-reporting biases and that are sort of positive, positive biases that people have about themselves and their relationships. Clients, for example, often have a hard time saying negative, things that are not positive about their therapist. If they, we see that in the relatively high scores on the working alliance inventory, for example, and other things. So, and actually that part of the question, I think I should probably give that over to Catherine, because you probably know more about the difference between self-reporting ruptures versus observer ratings of ruptures.
Yeah, observers see a lot more than we get from self-report. Now, of course, it's possible. Maybe observers get all excited about ruptures and we're seeing them everywhere, right? That's possible. But there's also evidence to suggest that sometimes patients and therapists are underreporting missing things or feeling uncomfortable saying something's going on. I think in some situations, we get a high alliance or a no rupture kind of outcome from a self-report. And I don't know whether that's because things were great or if that's withdrawal. So to me, the most important thing is we need multiple measures from multiple points of view. And also, as observers, I don't know what the patient or therapist are feeling, so I can't assume I have the perfect perspective either. We really need all of them. And then the really interesting part would be to look at when they converge, when do they diverge, and how's that related to outcomes and other processes.
Would you say that the patients in your sample, that they are more avoidant or anxious or psychosomatic than, for instance, other patients with more serious personality disorders mixed in?
I mean, I would say, oh, sorry, go ahead.
I'm sorry, I don't know if he was, Steiner, were you referring to the binge eating group or Catherine's research?
I think I was referring to what you presented. Maybe what you presented, or
what I presented.
Yes.
Oh, okay. So the binge eating group, I think we're more avoidant in terms of their personality. If we look at their interpersonal problems around the circumplex, they tended to be more submissive and avoidant in style. And I think that's why we saw so many withdrawal ruptures.
Yeah.
Sorry, Catherine, I interrupted as well.
No, I was good. Yeah, I'm also, a lot of our data has been with also more people on the more avoidant side. And this is why I'm hoping that these kinds of presentations inspire people working with in different contexts with different samples to do this work, because we need that more diverse set of studies to help us really understand these phenomena better.
Yeah. There's an interesting question about therapist characteristics. I don't know if we have time to refer to that.
It's already time for today.
Okay.
Maybe it's an idea to answer Pauline. It's her question. You do that by email. Is it an idea? Is that okay for you, Pauline? That we send you an email. Very good. Yeah. Back to you, Gianluca.
Okay. Thank you again, Catherine and Giorgio, for your wonderful presentations. And thank you to all the colleagues who have attended this webinar of our SIG. And we hope to see you again soon in our next webinar that we will be held. When, Marjolaine, do you remember?
Yeah, that's that date? I made so many mistakes with the date, but it's on March 13th, on a Friday again. So it's with Gary Burlingame and Bernard Strauss. So we hope to see you again.
Yeah. And we hope to see you again in Japan, of course, in June.
At the SPR conference, yeah.
Yeah.
Thank you so much, everyone.
Great, thank you.
Thank you.
Thank you. Thank you. Everyone. Bye. Have a nice weekend.